We will now invite Prof. Erwin Loh, Group Chief Medical Officer and Group General Manager of Clinical Governance at St. Vincent's Health Australia to share on putting patients at the heart of decision-making. Prof. Loh, please.
It's working? Yes, it is. Look, it's great to be here. Thank you for having me, and thank you, Professor Tan. He's finished a bit early, which means I can go a bit longer, which is fantastic, although there is a 30-minute clock there. Look, my day job is as the Group Chief Medical Officer for St. Vincent's, which is a third largest not-for-profit health provider in Australia. And I also happen to be the Vice President of the Royal Australasian College of Medical Administrators, which, if you didn't know, medical administration is actually a recognized specialty in Australia. We do have a training program, and the college conference is actually happening right now. So I've actually abandoned my own college to come and speak to you today. So hopefully you appreciate that. So I'm here to talk to you about putting patients at the heart of everything that we do. And this is particularly important because this is a value-based healthcare conference. And when we talk about value, we can look at value in terms of money. We can look at value in terms of the relevance to the provider, the hospitals, the Ministry of Health, the country. But clearly there is a value to care to patients, right? And when it comes to patients, we are all patients. So what is value? What does it mean to us? What matters to us most when it comes to our own health? That's what we're going to talk about. So I'm going to start off by acknowledging the traditional custodians of the lands on which I've come from in Australia. For me, I'm from Melbourne, so it's the Wurundjeri people of the Kulin Nation. And if there are any First Nations people in the audience, I want to pay you my respects. So I do have an interest in this topic. I've written about how we should bring back care to healthcare. I've talked about kindness. It was a fantastic session this morning with the consumers from SPAN. You have a really good group of people there. But kindness, what is kindness, especially during COVID? I've talked about variation. I've talked about shifting the focus back to the patient. I mean, we all talk about having patients in the center when it comes to our vision and mission of our organizations. Patient-centered care is a buzzword now, right? But what does it truly mean? And when it comes to kindness, it's one thing to talk about, let's all be kind to one another, but the systems that we have built over time have structurally embedded unkindness, all right? Yeah, I can be kind to you, but if you're forced to work long hours, if you're not being paid appropriately, you're going to be perceived to have, being treated unkindly, not by people, but by the system. So we're going to touch a bit about all of that, right? So let's start with astronomy. Some of you here might like space. When I was growing up, I wanted to be an astronaut. And if you look up, wherever you are in the world, if you look up at the sky at nighttime, you will be seeing stars rotating around the Earth. And in the daytime, you look at the sun, and it'll look to be rotating around the Earth. And because of that, Ptolemy, in around 100 AD, he looked at the universe, and he assumed that the Earth was in the center of the universe. I mean, it would make sense to assume that, because if you look up in the sky, everything was revolving around us. Does that make sense, right? But we know that that's not true now, right? So, and Copernicus came in the 14th century, Galileo in the 15th century, you got Kepler, he came along, and they all figured out that, in fact, after thousands of years of people assuming we were at the center of the universe, we realized actually the sun is in the center and we were revolving around the sun. But they were persecuted for that, right? When they first proposed that idea, the church came against them. Now, so no one in this room, hopefully, believes that the Earth is in the center of the universe. And this is how they figured it out, right? If you assume that the Earth is in the center, and you plot the orbit of the planet, so that's the orbit of Mars, you will see that it doesn't go around the Earth in a circle. It goes around the Earth in a very strange pattern if you assume the Earth was in the center. But if you take a different approach and you assume the sun is in the center, the orbits actually are very neat. They go around the sun very neatly. And so with geocentrism, which is the Earth being in the center, you get this really weird diagram, model of the universe, whereas with heliocentrism, everything's neat, right? There is a point to this, okay? So with geocentrism, everything's confused and it doesn't make sense. So it reminds you of this model where if you are the patient and you're experiencing the health system, you experience it in a very strange way. Even though the health system is saying, we want to put you at the center, you're not, all right? And all of us have felt this, right? I know a lot of you are healthcare professionals here, but you've been patients, right? So a few years ago, when my youngest daughter was probably about 3, she had a really bad asthma attack. And at the time, I was the chief medical officer of the health network, not my current one, it was a different one. And I was thinking, look, we had a pediatric hospital. I'm going to bring my daughter to my own hospital. She's going to get the best care. It's going to be okay. So I turned up. I didn't pull any strings. I didn't call up ahead and say, you know what, I'm the chief doctor. I'm going to come. I just turned up without telling anybody. So I was treated like anyone else. And so, like everyone, I had to wait. In the waiting room. Then I went in. I saw the nurse. I saw the doctor, I saw another doctor. I then had to wait to go to radiology. No one spoke to one another. I had to keep repeating my story. And to me, each of the different teams were orbiting around themselves, not orbiting around me. Does that make sense? So why is that? Why is that the case, right? Are we really providing patient-centered care or provider-centered care? Is it really provider-centered, right? So this is just a summary of St. Vincent's. So I work for a network. We have 6 public hospitals across Australia. We've got 10 private hospitals, 23 aged care facilities, 22,000 staff members. So we are large. And in 2015, the board of the network, this is before I came on board, they decided to go on a strategy to improve patient experience across our group. And so they came up with this vision and what they call an Inspired to Care program to improve patient experience. And one thing that they did was to start measuring it using the Net Promoter Score. I'm not sure if you're familiar with the NPS. It's a measure of consumer satisfaction across all industries, not just in health. And so they started doing that in 2018, and that's when I joined St. Vincent's. I joined St. Vincent's in 2018. They started doing it, and when we measured the NPS across our hospitals, both public and private, we found that there was a massive range. Like some hospitals were above 90, some were at 60. So there was no consistency. There was no specific strategy, right? So when I started, I came up with a program where we defined what an exceptional experience was. We came up with this tagline saying that patients are our purpose, our residents, so our aged care residents, our reason, and that we wanted to create an exceptional experience for every patient or resident every time. So that was high-level strategy nationally, and we just then worked with our hospitals to implement it in a very practical way. So this is an example that's come from our Sydney Public Hospital. I'm not going to go into detail, but it was at the hospital level, we wanted to build awareness and capacity. We wanted to encourage diversity and inclusion, and this included people from other backgrounds, refugees, migrants, people from different sexual orientations and different religious backgrounds. We wanted to make sure that there were opportunities for engagement, so having a consumer engagement framework where we had a consumer on every committee, all committees, and all the way up to, and at some point we will include consumers on our board, and supporting them to participate, closing the feedback loop as well. I've just realized as well that my eyesight's not that great. I can't even read that on the screen. I have to look at very small text. And start to ask the question, what matters to you? So this is an interesting thing, right? What matters to the doctor or the nurse can be quite different to what matters to the patient, because we assume patients want to be cured of the disease. I mean, that's why they've come to you. You've spent years studying to fight disease. And so when they come to you, you think, I'm going to cure them of the disease. But like, I'll use an example of a family member who, when she was 30, she was diagnosed with, she developed a lump on her neck, and she was diagnosed with thyroid cancer. She went to the best cancer hospital in the country at the time, because at the time I was the deputy chief medical officer of the hospital. I said, come to our hospital, we'll treat you well. And she did. She got theranostics, radioiodine treatment, and her cancer was cured. She's, this is now probably 15 years after that, and she's been completely cured. But she's never going to go back to the hospital, because although she was cured, she felt that she didn't receive the care or kindness that she expected. She was made to wait. She turned up for appointments that weren't booked. The surgeon who did the thyroidectomy was actually quite rude, even though he was a professor. And so what mattered to her wasn't just getting cured. It was a lot more, right? So we asked the question, so what matters to you is something that we ask our patients. So what we do is when we ask our patients this, for example, in one example, and this is a real life example, what mattered to them was they wanted someone to hold their hand when they were getting an anesthetic. So we organized that. And was another case where a patient of ours, she was dying, and we wanted to know what mattered to her the most. And what mattered to her the most as she was dying wasn't her family members, wasn't her pain, it was someone to look after a dog, right? And so we organized that for her. So that was really what mattered to her. And we put that into our forms now. So this is an example from one of our private hospitals, admission forms, discharge forms. What matters to you at every stage of your journey? Let us help you with that. And we have, like a lot of you now, a communication board in every room. That question of what matters to me comes up. So the name of the doctor, the name of the nurse, the name of the patient, obviously, but allergies and what matters to the patient, right? So we kind of do that. And so we implement a lot of these things across all our hospitals, and we started to create an evaluation framework because what you measure makes a difference. So we created this kind of triangulation method where we use the real-time Net Promoter Score, which is SMS to every single patient that comes through. You get a text message the moment you discharge with a link to give us feedback immediately. Then twice a year we do RPEX, which is the Australian Hospital Patient Experience question set, which is the Australian Commission for Safety and Quality in Healthcare. That's a standardized patient experience survey so that we can benchmark in Australia. And then we do HCAHPS, which is the Press-Ganey HCAHPS, so that we can benchmark twice a year, so we can benchmark internationally. So, like I was saying, the Net Promoter Score is a text message, very easy to use. And to give an idea of a good NPS, if you're not familiar with it, 30 is in the middle, 70 is excellent, because you start off with promoters versus detractors, right? How many of people are promoting you? And in health, what they say is that 30, 40 is not bad in health. So we use a company called Qualtrics. They create a platform for us where at every single level, you can drill down from group-wide, national Net Promoter Score, down to a ward. So if you are a NUM, a nurse unit manager ward, you can know your score for your ward using this live. And we not only get people to score us, if they choose to, they can send us text feedback as well, qualitative feedback. And that comes in live. So you can actually, if you are head of a unit, if you're head of cardiology, you want to know your NPS for your unit, you can watch it live come in, and you can watch comments come in. And this is, the reason why we do this is because then the nurse unit manager, if they find a complaint, they can deal with it straight away and on the spot. And we do also use AI and neuro-linguistic analysis to analyze the text and then get some themes. And so just to show you our results, so from 2018, we were kind of averaging about 60, 65. We went up to 69. Went up, peak at 80 actually when COVID started. And now we are sitting at about 76, which is pretty good. And if you then look at our RPEX score, which is a benchmark against Australian counterparts. We are leading the way, sitting at above 90. And then HCAHPS, as a group, we are sitting at 74.9 with 68th percentile internationally, and our private hospitals are really in the top quartile of private hospitals, so really doing quite well. And that's not doing a lot, right? That's just really listening to our patients, finding out what matters most, doing a lot of customer service training. And the perceptions of our doctors and nurses have remained quite high. And this is surprising to me, actually, because I've come from other hospitals. You can get really good high scores, but usually patients are not that happy with the doctors and the nurses but at St. Vincent's, we've done very well there. And we know that this is a real score because not only have I triangulated the NPS, RPEX, and the HCAHPS, we get results from our private insurers. So this is from Medibank Private, the largest private insurer in Australia, and this is their score for our private hospitals. We are ranked number 1. First time this year, last year we were number 2, the year before we were number 3. We've gone up to number 1, we are very proud of that, for PREMS and for RPEX as well. So they do their own RPEX version. So we are number 1 in Australia now. And so our aim is to hit an NPS score of 80 by 2025. And so you're sitting there going, oh, that sounds pretty good, Owen. You're doing well. That's enough, isn't it? Well, it's not, because as I go back to the original premise, we have still designed our systems to be provider-centric. And it's for good reason. It's because all of us are health providers. We want things to work for us. And so a GP, we want the GP clinic to have IT systems to be automated, to work for them, to look after the patients. A radiology provider, however, wouldn't really care how a GP practices. They will create systems to suit them. As a patient, if you want to book yourself in to see the GP, you go to the GP, call the GP up, find an appointment that suits the GP, not suits you, and then the GP refers you to an X-ray. Then you got to find out when there's a gap. Nothing is designed to suit you as the patient. It's all provider-centric. No matter how much we say we want to be patient-centered. So what are we going to do about it, right? So at St. Vincent's, we think that the system's broken, okay? Fundamentally, we can tweak at the edges. We can try to be nice to patients as much as we can, but structurally, it's not patient-centered. So we have, just this year, we've redesigned our divisions so that there is a hospital division. We used to have a private and public separate divisions. We now one single hospital division, one aged care division. We have created a new division called St. Vincent's at Home. And because we believe that the future of health is not going to be in hospitals. We cannot build enough hospitals. People are just going to get older, as it's happening in Singapore. They're going to get more chronic disease, and there won't be enough beds. So we need to be ready to look after people in their homes, right? And we created a whole division of digital health because the only way we can do that is with new technologies. And it's great that Professor Tan kind of went before me because he's talked about prevention, right? So this is the future of health. The future of health is true healthcare. The health system needs to be a true health system because at the moment, the health system is a sick care is an illness system. It's not a health system. People come to us. We are paying people to be sick. The system's incentivized for us to be paid to keep you sick in one sense, right? Because as Professor Tan saying, no one's getting paid to keep people well. So the system's broken, right? So we need to switch to a healthcare system that focuses on wellness. And somehow we need to get paid for that. We need to pay people to do that. And so that model is right to be disrupted. We need to create a system where the journey for the patient covers virtual, ambulatory. We need to keep people at home, as I was saying, so that we treat people where they're at. We don't expect them to come to us. We need to create an ecosystem, just like we have in the airline industry, right? So, for example, you want to book a flight, you kind of go onto your phone app. That's what I do. Qantas, you're going to look up the different flights. Yeah, this suits me, this doesn't suit me. And then I work through that. I get my booking, you check in, I get my boarding pass. Everything's done through an app to suit me. Bearing in mind, there's been a lot of cancellations and delays. But then the third thing then is redesigning our current system to increase value and decrease. I mean, this is the whole conference, right? Reduction of waste. But it's not only just a process redesign. It's not only just building in automation, using IT, using AI, but it's 3, job redesign. We need to redesign our jobs. There are not enough nurses. There are not enough doctors, right? We need to have third-tier healthcare professionals, healthcare assistants. We need to think about how we upskill other professions to do some of the work so that every profession's working at the top of their practice. And the 4th thing is we need to reform how we fund health. The funding system does not work at the moment. Why? Because it's completely based on fee-for-service. It's activity-based, and it's the traditional, if we're funding inputs, with no consideration of whether there's any value at the other end. We don't know what the outcome is. We are not paying for outcome, we're paying for activity. And because of that, and the activity is based on illness and sickness, right? So the more sick you are, the better it is, the more people get paid. So how do we change it to be an outcome-focused funding model, outcome-based funding? This is all about value-based healthcare, right? So that kind of revolution hasn't really happened yet. How do we pay people to be well? How do we pay people for good outcomes instead of for activity? So we need to look at that. And ultimately, this is the ecosystem we need to build, right? It's having I don't even want to use the word hospital. Healthcare that includes hospitals, but health truly around patients, truly around us, all right? Because we are patients. How do you do that? That's the future of the health system. Now, at St. Vincent's, we believe we can't wait for the government to do this. I know in Singapore, the Ministry of Health is trying to do this, and the government's trying to do it. In Australia, there's no way the Australian government can do this because the Australian healthcare system is broken between the Commonwealth and the states. They just Commonwealth funds primary care, states do the hospitals. So at St. Vincent's, because we are our own organization, we control public, private, and aged care, we are trying to do this, okay? We're trying to come up with a model where patients can pay us to keep them well, so that if they become sick, they can come to us. But that we need to be incentivized to keep them well. And wouldn't that be great? Isn't that what we all want, right? To be well, and rather than pay someone to treat you when you're sick, you want to be able to pay someone to keep you well. So that's a future of the health system. And if we don't do it, I really believe that someone else is going to do it. Big tech's looking at this, okay? So Google, Apple is trying to figure out a way to monetize this. I know the insurance companies are already looking into this. So it's something that we need to look at. And I think, but if we can do it properly, then that is true patient-centered care, all right? That's when, to you as the patient, you can pick up your phone, open an app, and say, oh, guess what? I need to see my GP for something, and this is the time I can do it. Pop. Oh, I need to have an operation. This is the time I can do it. I'm going to put it in. I'm going to book myself in, all right? I'm going to pick the surgeon or whatever it is. So true patient-centered care is where it is seamless. You do not see different teams where, then that requires major system reform. So that's my proposal to you, that ultimately we need to keep our patients at the center, and we rely on us to do it. We can't expect anyone else to do it. So we do have some time, and I'm happy to have a bit of a discussion because this is a small room. So I'm going to open it up now. Any questions by anybody? Because I've given this talk in a couple of places, and it can be provocative, right? Because I'm challenging the status quo here. I'm saying that the current system doesn't work, and we need to reform it, and it requires everyone to play ball. Everyone has to give up something, not for ourselves, so that our patients can be at the center. Questions? Yes.
Hi, Professor Loh. Hi, thank you for the very, very inspiring talk. I just wanted to ask you, based on your experience, does being more patient-centered result in higher costs to your health system?
It's a great question. It is a great question. And the short answer is it can go both ways. Now, in general, I would have thought that if your patients are satisfied, they're happy, they feel that they're getting good service, they feel that you're looking after them, I would have thought surely they would be willing to pay for it. Surely then they will be kept well, which then means that they're not going to be a burden on the health system, which reduces costs. So that would be the basic premise. Now, having said that, I suspect it'll cost money, actually, to build systems that make it transparent for the patient as they go through the health journey. So at St. Vincent's, I'll just tell you, we're trying to be very ambitious here, right? Because we do maternity care all the way to aged care facilities, all the way to PAL care, end-of-life care, right? So we think that we can create a ecosystem where we're not even going to call it patient-centered care. It's going to be called life-centered care. We're going to put your life at our center. You come to us, we'll look after you for life, all right? And we'll keep you well for life. And so we're trying to figure out a funding model to do that. Obviously, this is going to require technology. All of that requires money, actually. So to build the ecosystem will require a lot of funding and investment, but I think in the long term, you get the return of investment back. And in fact, I think it'll keep the population healthier. At the moment, it's all skewed towards the acute care end, right? I mean, we're going to agree. We are building more hospitals in Australia, more and more hospitals. But that's not the future. The future is to keep the population well. Yeah, right? So how do we do that? So that's a challenge. But, yeah, we're thinking about it. Any other questions?
Clive here. Thank you very much for both the presentations. Excellent. I was just snapping photos non-stop, of the slides. So in a way, the two presentations, Zili and Erwin, a lot of synergies, right?
Yes.
Because now for primary care, we are trying to, get it centered around primary care, and you talked about putting patients at the center.
Yeah.
So for Zili, practicing at the same place for 30 years, already very people-centered. So how much further can we push the envelope? And we also mentioned that the clusters now become regional health managers. So the clusters do have to work with primary care to be more integrated. So in that sense, do you have any advice for the hospital groups here on what they can do? And to Zili, how can we push primary care further to be more people-centered? Because I feel that it already is in some ways.
It definitely is. I mean, I'm very impressed by Singapore, really. Just Healthy SG strategy is amazing. I mean, it's really amazing. I think the fact that your GP networks are so mature, you're now enrolling patients. We don't have any of that in Australia, right? In Australia, the GPs, we've got primary healthcare networks, but at the most, they're still running as small businesses, and we don't have any of these patient enrollment programs. So, Singapore is doing very well. And I think GPs are the center of this. I mean, you can't do any prevention, and you can't do any community care without GPs.
So thanks very much for that, Clive. I think that the main challenge I face, is actually the environment. You can do a lot of stuff for your patient. You're actually, I am actually pressed for time and manpower to be able to do that. So the devil is really in the details, whether we will be able to upscale our services. But one of the things I think it's very important is whether or not we can actually manage the environment, meaning the environment they live in, the kind of food they eat, the kind of psyche they have with regards to exercise, and so on and so forth. Because I reckon if that could be addressed by whatever means, you have an ecosystem that could fly. But it's just being able to get to that point so that your system actually takes care of itself, becomes synergistic. Yeah.
I'll give you an example. So you raised a good point. So the socioeconomic drivers or the determinants of health play a huge part, obviously, that we need to look after that. To talk about, I think funding is one of the keys here. What you pay for is what you're going to get, right? So the current model, really just incentivizes people to just do activity. It's activity, activity, activity. Forget about prevention, because that's how you get paid. And to change that, I'll give you an example, all right? So Netflix, all right? Netflix, you pay a monthly fee. You can watch as many movies as you like, right? And yeah, you can pay a bit more, you get HD, right? You pay a bit more, you can have shared, you can have more screens. There are some that, Amazon, Google are looking into this, right? So in some GP practices in the US, that's exactly what they do now. You pay a monthly fee, $30 a month. See your GP as many times as you like. Your GP is incentivized to not see you, so they want to keep you well. So if we did that at St. Vincent's, we thought about it, right? People pay, so we become the insurer. Now it's tricky because there are laws around this. You can't just be an insurer, so we don't want to be an insurer because you can't. But if people pay us a set fee with different levels, for example, we are incentivized to keep you well, so you don't come into a hospital. Because what you're saying is you can come to a hospital as many times as you like. You don't get paid more. You don't have to pay more. But then we want to keep you out of a hospital. This is what the insurance companies are doing, really. So we are incentivized to keep you well. So what then I'll do is I'll give you an app. I'll say, if you follow this app and exercise this amount of time, do this amount of steps, eat this amount of food, and you log it in, you will pay less. If you don't do it, you're going to have to pay more, because that's just the way it is. So kind of like insurance, but not really. Does that make sense? So if you change the funding model to that model, where we're not getting paid for activity, but because at the moment, the more times you come to us, the more money I get. So please be as sick as possible and come, right? We need to change the model, right? We need to change it. So to one where we actually make more money if you don't come to us. So let's figure out how to do that. I mean, I think, to be honest, I really believe that that's the future. And someone's going to do it. So, someone needs to think about how to do it. Yes.
So we talk about patient-centric and provider-centric. I'm just asking, I don't think it's one or the other. Maybe you can give me an idea of what you think. Where is that answer? Because I don't think we can, because we have to organize the x-rays. I'm trying to think we will never get, what do you mean?
I know, which is why it's hard. When I wrote the article in MJ Insight, I mean, it's still a lot of debate, really. It's a controversial idea, right? It is, I akin it to the whole shifting from geocentrism to heliocentrism, because geocentrism was around for thousands of years, and it took a long time for it to shift. It was very difficult for people to get their heads around it. And it's much harder for a system where you have different companies, private companies, competing with one another, needing to be efficient in saving money, and their value base is very different to what's valuable for the patient. Does that make sense? And so it's hard. It's hard to do because everyone needs to coordinate and agree on an appointment system, agree on, working with one another when they are private companies with shareholders and bottom line. Easy for us. So this is why I'm saying St. Vincent's is trying to do this because we control the ecosystem. I mean, we don't control X-rays. We do some of our, we do have some radiology departments, but not all of them. So we don't control the whole ecosystem, we control a lot of it. So we think we can do a lot of this. But you're right. It's easy for me to stand here and say, yeah, let's go patient-centric, let's not be too provider-centric. Now, I'm not suggesting all the healthcare professionals which are burnt out under stress. I'm not suggesting you're not doing a good job and that you should all just be nice to patients all the time and forget about yourselves. No, that's not what I'm saying at all. I'm saying the structure is not right at the moment. And I'm saying it's not easy to change either, right? In Australia, I think it's almost impossible because Medicare, the insurance for GPs and specialists, it's fee for service. You get paid for operations and things. You can't, it's so embedded in the system, you can't take it out, I don't think. So it's about creating, it's like Uber, creating a separate system that people can choose to go to, right? Because taxis are still around, but Uber is Uber. And then Netflix, cinemas are still around, but Netflix came up with their own system. So it's about creating a parallel. And like I was saying, if we don't do it, I reckon big tech's going to do this. They're going to figure out a way to do this And, and then there'll be a shift. But the shift's coming anyway. I think Singapore, to be fair, you are really doing it quite well. You've got a good strategy. And because you're a smaller jurisdiction, you can probably do a lot of this, I think. Yes.
Yeah, I was just thinking about that question, and I'm just sharing my perspective as a a caregiver. Okay, many years ago, I think this is really more than 20 years ago, I visited Mayo Clinic, and I think Mayo Clinic they organize their specialist services around the patient. So what I learned when I visited, I don't know how true it is, that the patient goes in for a consult. In that very same sitting, the specialist will come in and they will have some, decision and conversations around the best appropriate treatment for the patient, and everything is resolved within 1 or 2 days. But when I was as a caregiver, I brought my aunt. She had cancer, so we had to see the oncologist. Then after that, we went to separate appointment, going to see the surgeon. Then separate appointment, going to see the therapeutic interventional radiologist. And after that, we were referred back to the, the oncologist and all that. So I think, maybe we can rethink the experience around the patient. Yeah.
And a lot of work has been done around certain disease groups. So diabetes is a good example. In diabetes, a lot of teams have gotten their act together so that when you go turn up to clinic, it's a multidisciplinary or interprofessional clinic where you see the doctor, the diabetes educator, endocrinologist, whatever. It all happens. So you're right, there is, and that's exactly what we're trying to establish actually. So it's creating this ecosystem around certain common disease groups, like diabetes is one, heart disease is the other one that's obvious. Some conditions will be hard because you do need to see multiple specialists, and it'll be almost impossible to get them to say, we're going to come together. I mean, it's not possible. But in some other instances, you may be able to do it. So, but it's a good point that you raise, yeah. Anyway, my time is up, so thank you, everyone.
Thank you, Prof. Loh. We have come to the end of the breakout sessions.